in Pathology Queensland, you'd know that troponin is a really evil word, and particularly at the moment, and it's certainly occupied my life for the last nearly 12 months, and it's absolutely horrifying. And hence I've titled this The Good, the Bad and the Ugly. Now, some of the things about troponin I knew before I actually came on board with Pathology Queensland, but I've since been hit with it full on in the face since I've been here. So I just thought I'd just talk about it, and hopefully we've cured the problem. So the good thing about cardiac troponins has been that there's no doubt that they have changed the face of myocardial diagnosis. Prior to the cardiac troponins, we used to really just have three categories, whether you either didn't have a heart attack, you had some form of angina, or you had an MI. The advent of the cardiac troponins allowed, and in fact caused, the American Heart Association to actually redefine that to acute coronary syndromes, which is a sliding scale of events, right through from someone who's just probably had some atrial fib, right through to the massive STEMIs as we know today. So there's no doubt that it's great. There's a few problems with troponin, and they're not going to go away no matter how good the assay is, and unfortunately these are just related to the physiological limitations. One of them became really obvious to me once when I was in PNG, and that's this idea of reperfusion. You know, if someone has a heart attack, that it is blockage in one of the blood vessels, and that means that sometimes they require reperfusion before you'll actually see some of the troponin out in the peripheral blood, which is where we take the sample. When I was in PNG, there's a big problem with Western lifestyle meeting thrifty phenotype up there. One of the very large police officers out in an outlying village had a heart attack. They'd pushed him into a PMV and raced him to the clinic, and the doctor in the clinic had tried for almost 40 minutes. I arrived and they were in the middle of a resus, and the doctor tried for about 40 minutes to get this guy back, but unfortunately he was unsuccessful. And during that time he had performed many point-of-care troponins, and they were all negative. He then sent a CK to the lab, which of course came back greater than 300, and he said, shook his head at me and he said, we have to look at getting a CK&B assay because there's something wrong with that troponin assay. And that was prompted me to sort of talk to them about this idea of reperfusion. Reperfusion is really what needs to happen for you to salvage some of that cardiac tissue, and so that's done with what's the name of the procedure that we do? Angiogram or angioplasty to reperfuse. So if there's no reperfusion, you're very unlikely to see any troponin out in the peripheral blood. The other problem is too, it's how they present, and this is, I guess, what we see in this heterogeneous presentation of the troponins that we see. If anybody is aware of, or ever heard of ischemic preconditioning, it's a condition or a phenomenon within the body which means that short periods of hypoxia can actually set up downstream events that actually become protective from a large ischemic event. And that then allows the cells, if you like, the cardiomyocytes to break down in an ordered, regulated way, or apoptosis, which means that, you know, the body likes to recycle anything that it possibly can, and so in which case there's a very ordered way in which it breaks down the troponin and starts to recycle the contents of the cell. And that's opposed to necrosis, where there's just explosive cell death and the contents of the cell are released. So there's another problem. Of course, unfortunately, God made us all different, and so there's a lot of intra-individual variation in what makes up your tropomyosin molecules. And also, one of the hugest problems I see here is that just about every single person emerging through the emergency department gets a troponin. The other day we had someone query pregnancy, we did a HCG, I think the HCG was positive, but then they added on a troponin. It's almost like, you know, congratulations, and here's your set of steak knives. So unfortunately, and we do certainly see some complications with this, you know, people with AML, you know, no surprise that there's a little bit of back pressure on the heart there, and there's a bit of, you know, cardiomyocyte death, and we get some troponins. The other problem is the assay limitations. I don't know about you guys, but it's been 12 years since I've worked in the lab, but nothing's changed with immunoassay. It's still a really big, thick sledgehammer for use. It was tremendous, as I recall, in my younger years as a scientist when it first emerged, because all of a sudden these things were actually available to be measured, and we could raise an antibody against just about anything, and we could measure it if we could imagine it. And that was tremendous, but they really still are not as fine a tool as we'd like them to be, and nothing has changed. Yet for some reason the manufacturers of these kits seem to think that they're somehow much more sensitive and specific than they ever were. And anybody who's as old as me, you know, which is just about as old as the dinosaurs, would remember that we had a lot of reticence with reporting low levels of immunoassay. But hey, now, you know, a tenfold reduction from the lowest possible standard, and we're reporting it as if we know exactly what that number is, and we actually don't. So I'm going to talk a little bit tonight about the analytical sensitivity and specificity and the clinical sensitivity and specificity and where they've collided to bring about my problems. So as I said, limitations in physiology, all to do with reperfusion and how troponin arrives in the peripheral blood. Because remembering, depending on how those cells die, it's going to depend on what you're actually seeing in the peripheral blood. And the other, so with reperfusion, you can see here, quite in this graph, quite the differences between reperfusion and non-reperfusion. So with reperfusion, there's a very rapid rise in troponin, and without reperfusion, it takes a little bit longer to work its way into the peripheral blood supply. Now, I asked someone the other day, you know, the medical students actually, when I was lecturing them, has cardiac troponins made the diagnosis of acute coronary syndrome more sensitive? Well, it hasn't, because in terms of CK, troponin and CK arise at the same time. They come from the same source. So there's actually no benefit other than the specificity of having a cardiac troponin to measure. And both of them are affected by this reperfusion issue. So nothing's changed there. But this slide tells the story. I hate to take you back to those days of physiology. I know it's going to bring up memories of Anna Marie Barbie, but honest to God, that tropomyosin molecule is just a wonderful invention. If you remember, it has a big tropomyosin subunit. It has troponin I, troponin C, and troponin T all bound together. Remember, as the action potential, the cell depolarizes, the calcium channels open, calcium floods the cell, and it binds to troponin C. When it binds to troponin C, that causes a conformational change in that molecule and moves that inhibitory head away, which is the troponin I. It actually moves out of the road and allows the actin and myosin to get together, and there you have it, contraction. So in that tropomyosin molecule, all three of those troponins are there. But when it breaks down, there's a very ordered process if there's time. And the phosphorylases will break off the N-terminal end and then the C-terminal end, and you'll get a very ordered arrangement of the troponin fragments appearing in the serum. If it's necrosis, they may be less ordered. But what happens is you get this heterogeneous bunch of molecules in the plasma that are sometimes just the I complexed with the C, or the T and the I and the C complexed together. And so this makes it difficult when you're using an antibody to actually measure it, because then there's this thing called steric hindrance, which means that some antibodies are going to be able to recognise these troponin I molecules better than others. And so that's why you get differences between different methods. There's a lovely little picture. That's actually showing a couple of things. First of all, the steric hindrance, so whether or not the affinity of that antibody for that particular shape part of the troponin molecule, and also down the bottom here you can see this false background. And this is the problem, the main problem with our Beckman assay. Anybody who's got a little bit of soluble fibrin or a bit of junk hanging around, it just actually binds quite happily to the bottom of those RVs and doesn't get washed away, and it causes non-specific binding. Anybody who's done RAA or any of those earlier ELISAs are well aware of non-specific binding, but for some reason modern people have forgotten all about the fact. And that's what causes a background, because it will actually trap other antibodies that have got the tracer on it and give us a light signal. I had to draw these pictures for one of the cardiologists the other day who was very impressed. Although I still think he really still gets cranky about our false positive troponins. Anyway, so now what we're talking about is the analytical side of things. So when we talk about analytical sensitivity, we're saying how close can we actually measure to zero and be confident about it. And I would say, you know, normally what we would say is that we really can't tell you any less than the lowest calibrator. On this particular assay that we're using at the moment, the lowest calibrator is 0.31. But yet we're reporting results with confidence down to 0.04 and below. Actually, we don't stop and put less than in front of it until 0.01. So I would just say at a 10-fold reduction, that is, you know, ambitious at best. The specificity, when we talk about analytical specificity, what we're asking is how well are we actually measuring troponin? And what's the specificity of that antibody to the number of amino acids in that particular troponin molecule? So what we actually find when we put all that together, because it's all very well, and I've seen many, many presentations by the chemical pathologists here, which are all really wonderful and full of statistics, but actually don't hold a great deal of relevance for us on the floor. But what we do see is that at a cutoff of 0.04, we actually have a CV of 20%. So what does this mean? And I know you'll shudder when you see these Levi Jennings and these statistics, but it really is quite simple. It just means that between 0.02 and 0.06, it could be the same number. We have absolutely no idea. And that's performing on quality control material. That's not on patient samples that have just walked through the door with AML and all sorts of things. So this is at very best, that's the best we can actually do. And so there's no surprise that we have problems down that area. When we talk about clinical sensitivity and specificity, we're actually talking about a very different thing. We're talking about how useful a diagnostic test is at actually detecting a person that has the disease or excluding a person without the disease. And you'll remember all those LIC curves and determining of the true positives minus the true negatives and all that. That's what we're talking about with clinical. And it's a very different kettle of fish. And so when you start talking about a high sensitivity assay, that the clinicians get very confused because they think that our assay is analytically sensitive, but it's not. It's clinically sensitive, and we'll go on to talk about that a little bit more. So the sensitivity is the proportion of people with the disease that have a positive result, and the specificity is the proportion of people without the disease who will have a negative result. So what does clinical sensitivity mean? Well, this is how the history's gone. Our first troponin assays that came out had a cutoff that was way up here at 0.4. In fact, when I used to work in a lab 12 years ago, that was it. The old Abbott assay had a cutoff of 0.4. So less from 0 to 0.4, you hadn't had any acute coronary syndrome. Between 0.4 and 2, it was considered to be the realm of the anginas, the stable and the unstable anginas, and greater than 2 was an MI. And we had absolutely no problems except with the occasional heterophile antibody. So that was, for me, great. But you can see why they got a little bit upset about it, because if you look at the normal population and the population of people who have really had an acute coronary syndrome, we're missing out on quite a number of them. And this concerned a lot of people. And so that began the discussion of moving the cutoff point. And so they decided, let's look at it. So you remember, if you remember your statistics and your normal curve, the mean plus or minus 2 standard deviations explains 95% of your population. So let's try and make it explain 99% of the population. So let's bring it down to that 99 percentile. And at that level, you can see that it's much better at defining normal from the acute coronary syndromes. But remember, we have to have a CV of less than 10% at that 99 percentile. That was the limitations for any analytical assay at that level. So that still brought it up here if we add that extra 10%. So it still was doing a great job, but we were still missing out on about 10% of the people. Throw in again people who will have a high troponin but don't necessarily have an acute coronary syndrome. And that's the non-acute coronary syndrome illness. Things like right-sided heart failure and other things that may present. So often we see patients with atrial fib. And so you're starting to see now that this cutoff is not probably picking up more normal people than it is those with acute coronary syndromes. And unfortunately, that's fine for the emergency physicians. They're quite happy with that because they're pouring everybody into a big funnel and they're thinning them down. But for the cardiologists, they get very upset because they have to see people that actually haven't had a heart attack. So when we add in our 20% CV and our cutoff now, you can see that there's quite a bit of overlap between normal and abnormal. And whilst we're picking up just about every single person that walks through the door with an acute coronary syndrome, we're also capturing a lot of normal people, and as I said, it's irritating the cardiologists. So I've just included a couple of case studies just to highlight some of the problems that we have. When someone comes through the door, of course, the first thing that they look at is an ECG. An ECG, of course, is so simple and defining. It's just so much better than a blood test. Wrong. Unfortunately, in most cases, unless it's a ST elevation, MI, or something that's quite out there, they won't be able to pick it. They still require a troponin. So for the people that come through with a ST elevation, there's no doubt about it, and nothing's really changed. You know, see this patient here, we've got a massive CK, and when we've measured the troponin, it's equally, you've shown that classical increase in troponin. So there was no diagnostic ambiguity in that patient there, and in fact, they probably wouldn't even wait for the troponin result before they take that person like that for angioplasty, because reperfusion is the most important thing for retrieving cardiac tissue. However, this is the sort of thing that we see. We see these people that have a low, elevated, persistent troponin. And this is the question, what does this mean? And all these asterisks here are where where we've repeated the result, or we've done something to try and get rid of that positive result for the cardiologists who'll ring me and say, oh, what's going on there? You've made some sort of a mistake. Now, that could be a heterophile antibody. That could be someone who has just troponin leak from chronic cardiac failure. It could be all sorts of things. But just to give you an example of one particular, and these ones here where we see these jump in troponin, they're the ones that concern us. And often that will be something that's sample integrity. But just to give you an example that all of them are not things that we can dismiss, was this particular patient here that the cardiologist kept ringing me and telling me that there was something wrong with the assay, and he was quite sure that there was a heterophile antibody there, and could I send it to Brisbane for a heterophile antibody, and could I continue to repeat and recentrifuge the sample, and which we did, and you can see that we've done repeat testing on that. It's cost us an absolute fortune, and quite convinced that it doesn't fit with the clinical picture. And then he rang and said, well, what else can I do? And I said, well, let's do an I-stat. Let's pull out some of this guy's past samples and do an I-stat. And you can see here, we've pulled the I-stat, and yes, while it was negative here, the I-stat was actually positive there. So in this particular case, this troponin rise is probably real. But the problem is, how do we tell the difference apart? And this has been an ongoing problem, both from physiological terms and clinical diagnostic terms, and a lot of angst and a lot of, not yelling, but anger being expressed over the telephone. But the very, very good happened today. It's been very traumatic, but we finally got there, and we've got a new assay from Beckman. They've added an extra wash step, they've added a longer incubation period, and from all reports, the early validation makes it look tremendous. There's about between a 5 and a 30% reduction overall in all of the results. But the best thing I've seen today was a troponin table that had more negatives than positives in it. It was very exciting. The other thing that's happened is this rapid clot tube. We can actually, the tube actually contains thrombin as well as the silica on the glass to help with the clotting process, and it does give us a cleaner sample, and it also means we can have that troponin on the analyzer in very rapid times. Although we're not allowed at this point to go any faster than a 10-minute spin, it still saves the 20-minute clotting process. But this is the ChemLight. I can't make it any bigger, I'm sorry, that they've just released today about the new assay. And if you look here, you can see the scatter, that is the black dots, that's the old assay. The blue dots are the new assay. So all of those outliers and those flyers that we were seeing, which were probably sample integrity, which were probably some of the non-specific binding that I showed you, they're largely missing. What a difference one extra wash step makes, hey? And if you look here, you can see these are the number of outliers. Now, on the best possible samples sent into Royal Brisbane, they were 1 in 350 with the old assay. The new assay, they say, will be 1 in 1,500. So bring it on, I say. So thank you. Questions?
Why don't we use litHEPS, Donna, from ED, if we want to save time?
Now that's an awesome question.
Yeah.
And the only answer I have for you about the lithium heparins is that they're on the nose. They're on the nose in Brisbane, and I didn't quite realise why they were on the nose until when I arrived and I had an analyzer breakdown for 3 weeks because of a fibrin clot that went through it, and just my immediate instinct was to put everybody onto lithium heparin, and then I discovered that the reason why they don't like lithium heparin was mainly this troponin issue, because they blamed the sample. And they were quite convinced that the lithium heparin sample, the plasma sample, was a dirtier sample. Okay. But as we're probably well aware in the lab, the first time the sample comes through, there's nothing wrong with the lithium heparin. The problem comes that if you put it in the fridge and then you pull it out later, they may have fibrin bits and things in it. Okay. So I kind of played a bit of naivety in that point and got the plasma, but I wasn't going to change the emergency department. We were at that stage, I think, talking about the rapid spin tubes, because Neil and Jose had started that discussion with the emergency people before I arrived. So we just sort of waited for that to come about. So, and it was really largely DWP, so Curtis and Co. Yeah. Yes?
Why is the ISTAT TNI more reliable?
It's not.
Oh, so why did you put up that thing saying that did an ISTAT TNI and it was positive?
Oh, well, okay, so one of the ways that you rule out heterophile antibodies, I probably didn't explain that really well, is that each manufacturer gets an antibody and it will patent that. So every manufacturer has a different antibody. Okay. And so when somebody presents with an a heterophile antibody, the classic way is just to run it on a different manufacturer. Yep. And so that's how we look at that. But also there's a bit of confirmation. Yep. The Abbott TNIs are no doubt a little bit more robust. However, they still suffer from the same problems. And one of the biggest worries about the Abbott TNI, particularly the ISTAT one, is false negatives rather than false positives. And we've had a couple of those too. But you don't know unless you're running. It's been interesting today watching across the state as people have started going, oh my God, look at all the false positives. Because unless you go looking for them, you don't find them. Yeah. But it was my fault. When I first arrived, I said, well, that's it. We're just going to repeat everything that's within that range. And that just opened up a whole can of worms. And so other sites that have gone to doing duplicate troponin testing have been reporting much higher levels. In fact, they're really interested now in the old assay.